So good morning. Today we're going to talk about an item suggested by Joe Riley, pulse oximetry. We call it pulse ox. Basically, it's looking at the oxygen level in our blood. And that's what's unique. One thing that's very unique about this virus, it tends to drop our oxygen level more so than our carbon dioxide level. And carbon dioxide drives our breathing more so than oxygen. But we'll talk about that a little bit later as we get into the video. That is one thing that's creating challenges in terms of danger and death. It's also maybe an opportunity. Before we get into that, though, a couple of housekeeping items. Upcoming topics: people barely sick with COVID-19 are dying from stroke. Now, why is that? It's an interesting comment. You know, so many comments I get from viewers. It's like my medical practice and everything else. You think you went to school, you think you studied, you think you learned a lot, and somebody comes up with a question, you think, I'm not sure that's a good question. Then you find out you just didn't know the answer, and there's a whole set of questions back there. What do I mean by that? Somebody asked me about people having clots, and I thought they were talking about a thing called DIC, disseminated intravascular coagulation. It's clotting that happens when you go into almost any of the intensive care situations. It can happen from trauma. It can happen from massive infections. It can happen from breakdown of key organs. But no, that's not what this patient was talking. I mean, this viewer was talking about. The viewer was asking about clots. Separately from DIC, from that intensive care experience that that a lot of people are getting with COVID, there seems to be a clotting problem, and we're going to cover that. It's not only like many areas where you get clotting mostly in arteries. It appears that the clotting associated with COVID-19 or SARS-CoV-2 or the coronavirus also causes clots in the veins as well. That's probably not going to be as big a problem as a clot in an artery, because once your artery clots off, you lose oxygenation. That, by the way, is one of the core disciplines, one of the core topics that we have in this channel. We're looking at clots, heart attacks, strokes, preventing those things. Those are happening routinely from basically cardiovascular inflammation and some problems that we have mostly associated with prediabetes. But this appears to be a totally different thing going on. But again, the end organ damage, the final insult to the body is increased clotting. Now, that's not happening with everybody. That doesn't appear to be the major mechanism with COVID-19, but it clearly appears to be a very important one. Janice was telling me about a fellow who's a Broadway actor who evidently lost his leg due to this type of clotting. It was a great article. We plan to cover that in one of the upcoming videos. Is it safe to eat takeout? Janice's birthday was last week. We've been in lockdown for, since March 3rd. And we have not, we usually eat out 2 or 3 times a week. We have not done any eating out. And we had not done takeout because we were nervous about it. I think, again, maybe another gap in my knowledge in terms of just looking out there. I've seen that a lot of people are eating out. I've been nervous about eating out. And part of it's my history. In my history, I've done quite a few workups, quite a few epidemic investigations from foodborne illness from restaurants. So I've always been a little bit paranoid in that area. Anyhow, we decided to go ahead and do takeout, and it was fantastic. We forgot how good food can be. We have some other items, coronavirus, hijacking the immune system, hijacking leukocytes, hijacking T cells. And you may remember, you know, that's one of the things that the HIV virus does. Had a couple of people, 146 Degrees West, I think, brought that up originally. Which U.S. states are doing enough COVID-19 tests? And again, obviously, the testing is a big, big issue. As I've mentioned before, I'm working with a large employer, a large consultant group, as in one of the, you know, the top 6 in the country, in terms of starting to get folks to understand employers to understand how to get people back to work. Huge issue. It's obviously going to involve improved COVID or SARS-CoV testing. Obviously going to have to involve some sort of improved antibody test, PCR. So we've gotten into the science related to those items, but got a little bit of update to talk about which states are doing enough in this area. Previous topics, if you have any interest, are finding effective treatments for COVID-19. We've covered several updates in that area. Pregnant women and coronavirus. What does it mean to be immune to the coronavirus? 6 conditions for ending the lockdown. And again, we shouldn't have put WHO there because everybody wants to hate the WHO. But there's a lot of correlation. It's not just the WHO. I mean, even Harvard Business School is consulting on what has to happen in order to end shutdown. And the correlation is very, it's not surprising. So again, all of us are thinking about getting back out. How do we do that safely? And unused coronavirus tests in the U.S. Our healthcare system is so fragmented. One of the biggest challenges, as we've mentioned a couple of times, is having enough appropriate tests. We can't do contact tracing unless we know who the cases are, and we don't know who the cases are if we don't do testing. And again, a lot of focus in that area, but it was a good example of how there were many places where the tests were available, they just weren't getting done because hospitals aren't talking to labs, et cetera, et cetera. Speaking of how to get information and coordinate better, one of the things we've noticed is that we've been having daily COVID-19 updates for people who are interested and to help explain some of what we're seeing from our viewpoint. As I've mentioned, I'm not seeing everything, and even when I do see something, sometimes it takes me a while to figure it out. But when we do that, we have Q&A, and it lasts these have typically lasted an hour. We're trying to decrease the time period, but also I've talked with Carl. He's beginning a system where he's taking the program itself, that 10 or 15 minutes where we cover the program, and putting that in one video, and then the Q&A in other videos. Again, just to help coordinate and not take up people's time. Speaking of which, we're starting to look at backing down a little bit as people continue to get used to this lockdown and this pandemic and what to do next. We're seeing a lot of the emotion calming down, but much more of a focus on, okay, what do we need to do to get back in the swing of things and do it safely? A couple of quick advertisement type things. We've got more and more people who are interested in the #1 risk factor, what appears to be the #1 risk factor for developing serious disease and death from SARS-CoV-2, COVID-19. COVID-19 is the serious illness, and that seems to be associated with the chronic diseases, as in high blood pressure, obesity, prediabetes. So we've had several different versions of this webinar before, and we've got another one opening up. We've had several people register already. If you're interested, please check it out and sign up. Now, the webinar itself is cheap. It's $199, and you get a ton of content. What you find out is, am I one of those 90% of people that have prediabetes over age 30? Half of us do. 90% that do don't know it. And am I one of those 90% that has it but don't know it? That's a great thing to know, because that's what's killing people from COVID-19. That's what's killing people from heart attack. That's what's disabling people from stroke. Again, $179 for the information, the digital information, the ability to go through this, these studies. And if you need to get the labs yourself, that's an additional couple of $100. So check it out. And as I've said before, we're busy. We've got a lot of stuff going on, but we have agreed we continue to offer 15 to 30-minute time slots for folks that just have any kind of physician type of question that we can help with. As you know, I'm a specialist. I specialize in preventive medicine, focused on cardiovascular diseases and chronic diseases. But I've run the medical staff for MDLIVE with 800 docs. Premise another 300 to 500 doctors. Again, all primary care, prevention, that type of stuff. If you're not able to access your doc by telemedicine and you want to stay safe and not go into a doctor's office, you can access that through us as well. So back to the topic today. We'll cover that right after Carl gives us the water ball. So Joe Riley is a friend, and he's been on a couple of our videos. Joe's one of these guys that has shared with us as a group that he's got not only world-class LP(a) levels, but also appears to have FH, familial hypercholesterolemia. So he and I have done a lot of work in that space, and he's one of those examples of how, you know what, you can have some major risk factors, but if you know what you're doing, you can prevent heart attack and stroke and remain healthy and remain comfortable that you can remain healthy. You just need to know. Hence some of these webinars about people finding out, you know what, I had the major risk for heart attack and stroke. I had prediabetes. In fact, I had full-blown diabetes, but my doc didn't tell me. I didn't know. Now that I know what to do. Anyhow, Joe keeps up with a lot of stuff, and he sent me a couple of texts and emails, and he got excited about this article, and I'm so glad he did. Thank you. I know Joe's watching. Thank you so much, Joe, for your contribution, both the financial contribution you made a few minutes ago, but especially for this information. I've known that pulse ox was a big deal, especially for this issue, but just totally forgot to cover it. It came out in a New York Times article, the infection that's silently killing coronavirus patients. Now, why is it silently killing coronavirus patients? Well, because it gets back to that comment that I made earlier. What's happening is that we're losing our oxygenation. Folks that get the SARS-CoV-2 infection and are going into the COVID-19 serious disease, lose their oxygenation, but they don't lose their CO2. So what does that mean? Again, hopefully we can bring some more light onto that. Here's a quote from Richard Levitan, an ER doctor and the guy that wrote the article in the New York Times. We are not detecting the deadly pneumonia that the virus causes early enough. And that we could be doing more to keep patients off ventilators and alive. In other words, if we detect this a little bit earlier, maybe we can prevent a lot of the death that's been going on, and the visits to the ICU and the visits to the ventilator. And we all know once you start getting to that state where you have to go to the ICU and ventilator, your probability of surviving has dropped dramatically. So Levitan, Dr. Levitan in the ER observed this. Almost all the ER patients had COVID pneumonia. Even patients without respiratory complaints had COVID pneumonia. So no complaints, but still an pneumonia infection in the lung. As we reported earlier, and the folks have reported all the way back to China in the early days of this pandemic, they were seeing what's called ground glass findings on the chest x-ray, even in kids. And the kids were not dying from this. They're still not. This is not something that's a virus that's attacking kids, but still a huge number of kids are showing ground glass. What that means is, whether we're aware of it or not, this virus does attack our lungs. It's just very silent and stealth in terms of its attack. It's like a ninja. So these patients didn't report any breathing problems. Chest x-rays showed that diffuse pneumonia, that ground glass appearance, that's what we were referring to in that earlier article. Their oxygen was below normal. So pulse ox and the silent infection that's killing us. The normal pneumonia, we've got a comparison here on this, these two pneumonias. A normal pneumonia on the left versus COVID pneumonia on the right. Regular pneumonia, or quote, normal pneumonia, is an infection of the lungs in which the air sacs fill with fluid or pus. It happens from some bacteria. It can happen from viruses as well. You get discomfort in your chest. You get pain with breathing. You get other breathing problems too. You're coughing. You keep coughing up stuff, and it feels like you just can't get all that stuff up. And typically, you'll get a significant fever, especially if it's bacterial pneumonia. If you look back at some of the significant problems in the history of medicine, when you talk about the discovery of penicillin, that was the big life-saving component, because prior to that, Streptococcus pneumonia was killing a lot of people. It was one of the major causes of death. After the development of those antibiotics, that became a thing of the past. So back to the script and the bullets here. Most patients requiring emergency intubation are in shock. They have altered mental status or are grunting to breathe. It's like this. You're pushing against your, you close your glottis and then you push, and that helps increase the pressure inside your lungs so you can inflate those lungs again. Now let's talk about COVID pneumonia. COVID pneumonia causes a form of oxygen deprivation called silent hypoxia. And it's silent because, again, they're not detecting it. We typically detect, quote, hypoxia, not because it's hypoxia or low oxygen. We typically detect it because our CO2, carbon dioxide, is increasing. So we're really the brain driver. The nucleus in the brain that tells us to breathe tends to be more driven by elevating CO2 than decreasing oxygen. So again, something to think about as we think about this, the mechanism for this disease. So patients don't feel short of breath for days or even as the oxygen levels are falling. They'll talk about in the ER, patients have incredibly bad oxygen levels, but they're sitting there waiting for a room, and they're working on their cell phone as if nothing's going on. By the time they begin to understand it, they already have alarmingly low oxygen levels and moderate to severe pneumonia, based on the x-rays that we discussed, that ground glass appearance. Patients requiring intubation are even using their cell phones. So they have a low oxygen level, as low as 50%. And the normal range for oxygen level is 94 to 100%. We start getting worried in the low 90s. So now you're beginning to get an understanding when you compare that to 50% oxygen levels, helping you understand how this is a very serious issue, but it's sneaking up on people. How does this happen? Well, the coronavirus attacks lung cells that make surfactant. What is surfactant? It's sort of like an oily substance. It helps the air sacs or alveoli in the lungs stay open in between breaths. It creates, it uses what we call surface tension. You know, when you drop a drop of water on the table and it'll ball up, that's surface tension. Surfactant creates surface tension within our lungs. So even though we exhale, we still, the alveoli or the air sacs still remain open. COVID inflammation causes air sacs to collapse and oxygen levels begin to fall. The lungs initially remain compliant. Now, what does that mean? It means I can, as you just saw me sigh, I can move my rib cage easily. And when they become non-compliant, it's usually, it can be for scarring. That's more of a chronic issue, but on an acute basis, it's usually due to lungs filling up with fluid. So early on, you get this drop of oxygenation, but the lungs are not full of fluid yet. So the patient doesn't understand. The person doesn't understand. I'm not having trouble breathing, but I'm not aware that my oxygen level's going down. They can still expel CO2. They don't feel short of breath. And that was what I referred to a few minutes ago. You don't get this increase in carbon dioxide, so you don't feel it. Patients compensate for the low oxygen by breathing a little bit faster and deeper, and then faster and then deeper. And that's this silent hypoxia. That breathing fast and deep causes inflammation. And it causes air sacs, irritation, inflammation of the air sacs. It causes the body to start, we get hypercapnic. You ever hear that term? Again, just a fancy medical term. What it means is decrease in CO2 levels. So as you get decrease in CO2 levels, that's when you start getting a little bit nervous and jumpy. So in effect, what's going on is the patients are injuring their lungs by breathing harder and harder. Now, 20% of COVID pneumonia patients go on to develop a second deadlier phase of this lung injury. The fluid begins to build up, lungs become stiff, the carbon dioxide now begins to rise because you can't ventilate anymore. Then they develop acute respiratory failure. So that's what's going on. There was a JAMA article recently on what the first 5,000 patients that were admitted, consecutive patients that were admitted to New York. And out of that group, they talked about 20% of them, I think, was going on into ICU and a high level of those dying. So again, what you're beginning to see is some parallels of what we've already discussed here in what's called pathophysiology. Patho meaning disease, physiology, how it works. So how does the disease work for this? First of all, you get an infection. Most people don't get a significant problem with it, but some people, as in maybe up to 20%, we don't know yet because we don't know the denominator. But some people start losing their ability to oxygenate. As they do, they get into a cycle. And a portion of those folks get into a destructive cycle that ends up injuring the lungs. Now, by the time the patient gets the fluid buildup, the lungs become stiff, the CO2 rises, and they develop this respiratory failure. Oxygen levels are now dangerously low. That's when you start seeing those oxygen levels at 50%, 60%. Patients will require a ventilator. And again, you typically ventilate a patient at higher levels, significantly higher levels than that. Many patients are not going to the hospital until COVID pneumonia is already well advanced. So as we discussed before, it's because they're not noticing that hypoxemia, that decreased oxygen. Many wind up on ventilators, causing shortages of machines. And once on the ventilator, many die. So that brings up another point. recurring theme that you've heard from many people, and that is that ventilators are killing people. That may be the case. Here's what I'm thinking currently. I'm thinking it's, it's what's always been the case. By the time somebody needs a ventilator, they're in very, very serious condition already. So what is pulse ox, and how can that help? So it helps to identify patients with COVID pneumonia earlier and then treat them more effectively. One way is through pulse oximetry. What is pulse oximetry? It's a way of monitoring the blood oxygen level. And you see pictures of it here on the right. So this is a way to know whether somebody's developing silent hypoxia. Provide early warning of COVID pneumonia. It displays both oxygen saturation, and you get a pulse rate with most of these. So who should have this? Well, all patients tested positive for coronavirus should be monitored, and all persons right now with a cough, fatigue, and fever, even if they have not been tested or even if they have negative results. I think right now it's a good idea to keep an eye on your pulse ox. Now, we had some discussion when Joe originally brought this up last week, and I made, again, an offhanded comment that Janice had told me these things were no longer available. I have been meaning to get one for a while. It's just that we don't use them. We're mostly focused on prevention. But when the coronavirus came up, I thought, gosh, it'd be nice to have one of these. And I just never got around to setting it up. Janice told me when I started to look, they're not available. Then we had some back and forth with the comments. I looked, and sure enough, you can get them now. You can't get the $20 ones. I think they're out. But I found several of them on Amazon for like $50. Carl, do you want to go ahead and show that 2-minute video covering this issue, and then we'll go into discussion, Q&A.
Well, when it comes to COVID-19, a tiny over-the-counter device may potentially save your life. Alan Martin joins us now with more on that. Alan?
It can. The new go-to gadget is called the pulse oximeter. Now, some health experts believe during this pandemic, you should have one by your side.
Your life.
COVID-19 can result in severe illness, organ failure, and death. The sickest of patients develop acute respiratory distress syndrome, a type of respiratory failure characterized by widespread inflammation in the lungs. But with this virus, the syndrome is strange.
Patients can have very, very low oxygen amounts, and yet they kind of still look comfortable.
Emergency room doctors are reporting how some patients are apparently walking around with pneumonia for days, getting sicker and sicker without developing any symptoms.
Almost unimaginable how people could be awake and alert and have oxygen levels that are half normal. Shortness of breath is a late sign.
That's why this device may help. It's called a pulse oximeter. Clip it on your finger and it measures the oxygen in your blood.
You know, normally we are 94 to 100% on these devices, these pulse oximeters. And people were showing up with oxygen levels of 50%.
And so you may not feel short of breath, but you look at the number and say, wow, I'm not getting enough oxygen. Call your doctor.
Dr. John Schwartzberg of UC is an infectious disease expert. He says with this device, doctors may get a patient hospitalized earlier, and that could potentially save lives.
Earlier identification of people who are going to be in trouble is that we can grab them before they fall off the cliff.
Well, the problem is the devices are a little like toilet paper was. They've become very hard to find. The prices have jumped if you can find one. You also need to know the home device is not quite as accurate as the one you would find in the hospital. Also, operator error is a problem. You might not clip it on correctly, and ladies, fingernail polish could skew those results.
Thank you, Carl. I've gone over to the Q&A section now, and we've got a lot of interest on. It's a good topic. Dave Murphy, good morning, Dave. Great to hear from you, and I appreciate you joining. And it was good to see you last night on Dr. Boz. We'll talk about that a little bit later. Joe Riley, the guy that brought this whole topic up, reminded me I needed to cover it. Thank you so much for reminding us, Joe. And I thank you for the contribution, Joe. For those, Carl, you may want to show guys how to contribute if they want. You can contribute on this channel. It's called Super Chat. I was asking about that on Dr. Boz's YouTube live last night. I got a great review on keto with her. She's one of the queens of keto in terms of helping people understand the details on how to actually live that kind of lifestyle and how to make sure that you're remaining ketotic. And it's not an unhealthy kind of keto at all. It reminded me of some stuff I need to be doing. So helped me get back on the wagon. Anyhow, if you'd like to contribute, you go down to the Super Chat. You can, right next to it, you can see a button where you can do that. That makes a big difference. Carl and some of the other folks that work with us are in the Philippines and are $5 in Filipino. The Filipino economy makes a big difference. You can also donate through Patreon. We're getting a lot of Patreon donations and signups as we're doing some of these YouTube lives. I think Michelle set up something for, gosh, what is it? I can't remember it right now, but we can talk about it later. If you have questions, we can help you figure out how to do that. John from Las Vegas. John gets to go out to, I think it's called Red Rock Canyon. Beautiful place, and does some rock climbing and hiking out there. And I can't tell you how jealous I am. Of course, I don't have it bad here either. Dennis Williamson, Joe Riley. Yes, Joe Riley. Tab Tingray, good morning, Tab. How are you? James Cantor. James, I appreciate you joining us today. And James says he has a pulse ox and he does use it. I am glad you do. James, you've shared with us that you're like me and a whole bunch of the other folks on this channel. You have problems with glucose metabolism. And I think you've shared that you have full-blown diabetes with the others. Depend on how you want to define it. A lot of us have full-blown diabetes and don't even know it. We get like 2 or 3 comments each month where people say, Doc, I took that OGTT and I didn't have prediabetes. I have full-blown diabetes and my doctor didn't know it. Again, this is not to beat up on doctors. That's the bottom line. They've done research on it. Doctors are not really paying that much attention to prediabetes. They just think it's, quote, part of normal aging. So guess why we have so many people dying of heart attack, stroke, being disabled with stroke, and thinking you can't predict it. Well, if over half of us have the major risk factor for a disease like heart attack or stroke and don't know it, 90% of us that have it don't know it, then guess what? It's not surprising that you, quote, can't predict a heart attack or stroke. Dave Murphy, thank you very much. Dave, again, hit a super chat. We showed you that a minute ago. Thanks again for all you do to keep us informed and educated. It was great to see you on Dr. Boz last night. Great to see you as well, Dave. Robert Simpson, hello, Dr. Awesome. Thank you very much, Robert. David Ivers, good morning. How are you? Susie Penguin, yikes, I have a clotting autoimmune condition. Well, interestingly enough, I'm going to go ahead and give you the punchline on that clotting discussion. One of the things that's coming up, and several people are considering, by the time we know that somebody's getting COVID-19 from coronavirus infection, maybe we should go ahead and start covering them with blood thinners, anti-clot mechanism. Well, guess what? I'm already on it. Why am I on it? I'm on Eliquis. You see Eliquis, Xarelto, you see some of those medicines. Here's why so many people are on it. The number one cause, or the number one cardiac dysrhythmia, or arrhythmia is what people used to call it, but that arrhythmia means no rhythm. You got to have rhythm or you won't be alive. Dysrhythmia means not such a good rhythm. Then number one, dysrhythmia is what? I've got it, atrial fib. And here's one of the things. We used to think that the term, I think, oh gosh, I went through that with somebody else recently, cryptic or stroke of unknown origin. Well, then we're beginning to find all those strokes of unknown origin, and by far the majority of strokes used to be, quote, unknown origin, we're finding out are due to atrial fib. Atrial fib like I've got, which is called paroxysmal atrial fib, fibrillation, which means your heart's beating at a normal pace on a regular basis, but then it'll go into atrial fibrillation on it may go into 15-second run of atrial fib. Well, these unnoticed runs of atrial fib appear to be enough to cause clots. So if you have paroxysmal atrial fibrillation, you probably don't know it, just like that 90% of people that have prediabetes don't know it. And if you have it, if you have atrial fib, your probability of having a stroke has just gotten multiplied by 5 to 7 times. And again, you don't know it. Now, most people that have atrial fib, at least most baby boomers, once you get to that age, probably need to be on one of these anti-clotting mechanisms. So like they're called NOACs, new or novel oral anticoagulants. Again, the most common ones are rivaroxaban or Xarelto and Eliquis, like I'm on. So again, maybe I'm jumping around a little bit, but it's an important concept. Again, another hugely neglected area in terms of health of baby boomers. Nancy DeBrozek. Good morning, Nancy. How are you? Dave Murphy. Happy belated birthday to Janice. Well, thank you very much. I'll tell her you said that. She remembers you from some of your comments and some of your earlier contributions, Dave. Again, thank you so much for helping us with the channel and helping us get that information out. Simra Basivan, thank you so much for information and teaching to us. You're very, very welcome, and thank you for your interest. Robert Simpson, is liposomal vitamin C better than regular vitamin C? I have heard and read that many, many times. Can I vouch for that in terms of my own review of the science? Not so well. Now, it's not because I have taken a hard look and spent hours reviewing the science behind lysosomal vitamin C. I have not. I just know that there's a huge debate around that area. Am I taking lysosomal vitamin C? Not right now. I'm just taking regular old chewable vitamin C's, about 1.5 grams a day. Good question. And I keep, maybe once COVID's gone and things calm down and I get a little bit more time, then I'll look that up and put some information out about that. In fact, you bring up a good point, Robert. We are, because the webinars have been so popular, we're starting to add other webinars. Over the next few weeks, for example, you'll see CIMT. Now, why did I go there? Here's why. We plan on starting to do supplement webinars as well. I've provided a lot of information about webinars. About supplements. As you can tell, I review the science. I'm classically trained. I'm an MD. I taught preventive medicine at Johns Hopkins, used to be an ER doc. So again, I'm approaching things from the same perspective that a lot of the regular docs, the standard medical community out there, except I have taken the time to look at a lot of the supplements related issues. Obviously not enough about lysosomal versus regular vitamin C. But anyway, because of that position and that background, I get a lot of questions about supplements. And when I've got an active patient practice, still active and open, love to see you if you have an interest. But quite often, patients and I will go down a bunch of bunny holes. As you can tell, I tend to go down a lot of bunny holes, but a lot of bunny holes on supplements. And I got this at the Louisville event. I'll get this from patients. Okay, I got it. That's helpful to know a little bit about the science behind these supplements, but what do you do? And we were better at talking about scientific evidence than we were at getting patients the information that they needed on a daily basis to make their decisions. Well, we've made a lot of improvements in that area on supplements. Laurie's come on board. She's a nurse. She's helped us straighten out some of the things in terms of getting to patients lists of the supplements that we recommend for prediabetes, diabetes. If you're one of those patients that's taking statins, supplements associated with inflammation, again, here's what to do. And she's actually got it in an easy button as well. So we're going to be providing more of that to folks that can't afford to or don't want to invest the money in becoming a full-blown patient. You can get it the less expensive way just by joining the webinar. So good question. Thank you for bringing it up. And pardon me for not being able to give you the exact answer. Dennis Christensen. I have read that COVID-19 patients who recovered after being on a ventilator appear to have long-term problems with both physical and mental. Can you elaborate on this? It's again, and I'm going to have to punt on that one as well. Batting 0 for the past 2. I don't think I'm the only one that has questions about long-term results with COVID-19. I mean, how long has it been around? Now, here's the thing. If you're that young actor, Broadway actor that lost a leg because of a clot from COVID-19, I think we all know that's really obvious some of the problems that you're going to be having. So for the folks that have had clotting problems resulting in permanent damage, that's a big deal. I think one of the bigger questions, though, is there permanent damage to lungs? And if so, what kind of damage? And I think that remains to be seen. Similar questions on the mental side. It's not like COVID-19 reliably causes major brain injury, but it does cause strokes, even in young people. So obviously, if you have a stroke associated with that, now, again, we already know what kind of long-term problem a stroke is. Strokes are the major cause of long-term disability. Now, is COVID-19 reliably causing strokes? Again, those are not the majority of patients. We're seeing the COVID-19, the lung problem much more commonly than we see the strokes in young people. So Joe Riley, 97%, 66 beats per minute. So Joe's got his pulse ox up and rolling, and numbers are looking pretty good. By the way, after that interaction, I think it was between you and David Murphy last week and me, I went ahead and ordered one of those pulse oximeters from Amazon. Had to pay $50 instead of 20, but hopefully it'll be here in a week or so, and I can tell you what mine is, my pulse oximetry. Jan H., may I suggest a YouTube briefing by a Cal in the Trenches ER doctor, Dr. Erickson, COVID-19 briefing? Well, you've got a bunch of those out there, Jan. Are you saying we should go take a look at the In the Trenches? I think I've seen Dr. Erickson. I've seen bunches of them from different ER docs. And I'm wondering if Erickson was the young doc. I think he's located in New York, and he was saying we're doing the the ventilator, all wrong. We should be treating this as elevation or mountain sickness. If that's the one, then let me know. Douglas Pohl, a substitute which tends to reduce the surface tension of a liquid in which it is dissolved, or a substance is. Dish soap is a surfactant. You know what? Did I use that term surfactant? I think I did, and thank you so much for fact-checking me, Douglas. If I use the term surfactant, you're exactly right. It does decrease surface tension, and I got it backwards when I was explaining that. Again, thank you. Appreciate the fact-checking. Joe Riley, if you detect your low oxygen level early, you could begin treatment and therefore save your life. Thank you, Joe. And thank you for suggesting the topic. Jackie Shaheen, the pulse oximeter I ordered Friday for my 75-year-old mother was delivered 20 minutes before this broadcast. Well, the timing is, that's good timing, isn't it? Dude Jason, lower priced pulse oximeters are 20 to 30 bucks as of now. Well, that's good to hear. Steve Mitchum, if I get my job back, I'll donate. I understand, and my son's significant other lost her job recently. She was running a Starbucks for a well-known retailer. I can't remember the name of it. Well-known to everybody else maybe, but this has been devastating. Steve Mitchum, Red Rocks is in the view from the bedroom window. So I'm jealous of where you live too. You and John evidently live pretty close to each other. At Rob, have used a pulse ox for years, just out of curiosity of my level. I just like to know, and I also use a Voldyne 5000 for lung exercises. I think you're saying lung exercises, and you're saying that's preventive medicine. John Panazzo, a plethora of statistics regarding COVID-19 have been published which break down mortality by age and comorbidity separately, but as yet, I have not seen them conjoined. For example, probability of death for the aged over 65 or 75 who have a comorbidity. Yeah, you know, once you start watching these numbers, John, it gets frustrating. Here's one of the numbers I would like to see. It seems like it would be, you know, early on, there was this question, for example, about ACE2 receptors. And the obvious question that I wanted to see was, okay, out of the people that had infection and went on to COVID-19 serious disease, the folks that got infection, what portion of those were on ACE inhibitors or ARBs? And the folks that had COVID-19 went on to serious illness, what portion of those had ACE inhibitors or ARBs? Such a critical, obvious question early on. I think people are beginning to relax and just become less worried about it. But why did no statistic in that area ever appear? Right now, again, one of the burning questions that we covered, and we'll talk about again a little bit later, is the, not today, but over the next topics, is this clotting issue. So obvious question here is, there are a lot of people, as I said, a lot of people now on the new oral anticoagulants. There are a lot of people on aspirin for prevention of heart attack and stroke. And again, the NOACs for atrial fib. Wouldn't it be very interesting to see proportion of people on that that get SARS-CoV infection and compare that to the proportion of people that get COVID and get strokes? And if there's obviously a major difference, then that gives you some critical information to know, should we actually start treating earlier with anticoagulants or antiplatelet medications, which aren't exactly the same thing. and that's another bunny hole I'm not going to go down right now. Jan H, sorry, the Erickson date got it all cut off. April 22nd, 2020, not in competition with you, Dr. Brewer. Oh, okay, thank you, and many thanks, Carl. So Jan H was talking about the, I can't find it now, but the ER doc that was talking about COVID-19, and probably some discussion about these related topics. Nancy DeBozek, I have a pulse ox and dumped a glass of water on it last week. Sorry to hear that. I can't find one. Oh, it broke it. Sorry about that. I can't find one now. Most of the ones on Amazon and eBay are shipped from China. I think I'd still take my chance. Obviously, I still did just take my chance on that. I didn't look to see, because even if it's from China, I'd like to have one. Janice has already told me, by the way, the hospital here in Lexington that she wants me to take her to if she gets SARS-CoV-2 and then starts developing hypoxemia. So I'm not quite as biased or opinionated as she is, but I think I'll just take the same hospital she wants to go to. I'm the boss. Clarify for us what Trump meant about UV light and injections rather than what the media spun. Well, I mean, here's the thing, and I felt sorry for Dr. Burke because she was put on the spot. I thought she handled it pretty well. Here's the thing, and it sounds like from part of the way that you've worded that you're frustrated with the media. And yes, he did get a beating on that, whether you like Trump or you don't like Trump. And we've got folks with, I'm not going to go there. We get both kinds, folks that like Trump, folks that don't. UV light and some other things like hydrochloric acid are shown to kill the virus. So here's one of the things that you begin to wonder. If they kill the virus, well then, is there a way to use those methods to kill the virus on our body or even inside our body? I mean, that's what that's an obvious next step from a logic perspective. And for those of you who don't know this, no matter whether you're pro-Trump or anti-Trump, Trump tends to think out loud. And frankly, I'm neither pro nor anti. I just not going to go there. He does tend to think out loud. And so most of us go through that logic. Well, if something will kill this virus, why would you not think about applying it to the human body? Well, here's the problem. Number one, with UV light, you're not going to be able to get it inside the human body. You think, well, maybe I could get it inside the respiratory tract. If you get it inside part of the respiratory tract, you're still not going to get it in enough places to get a good, the problem becomes in practical application of UV light. Now, are people using UV light in other areas? Yeah, I'm pretty sure they are. In fact, as I shared with you, I'm doing some consultation on return to work. That not only has to do with regular return to work for patients, it also has to do with cleaning up the environment. And the guys on our team that are consulting in that, David Vigorous, a virologist who trained and was faculty at Vanderbilt, really good virologist, great lab guy. And yeah, he's using those things, but again, mostly some of the simple acid, very simple acid. One of the clients is a large pharma manufacturer, and again, these guys get shut down. They get shut down for, it costs them millions per day. So whatever is necessary to clean that environment, they will do. The simple, easier stuff have worked very well. Now, then you get to the stuff about injections. You think, well, if that kills the virus, Lysol, for example, responded to this. They said, please don't inject Lysol. Let's say Lysol kills the virus. Well, would you think about injecting it in the body? Well, in a place where it hit the bloodstream in a high enough concentration, it might kill a few viruses there, but very quickly it's going to be diluted. Meanwhile, in that first couple of centimeters where it's hit a high enough concentration, it's also burned up your arteries, it's burned tissues, and you've ended up getting an abscess or a skin ulcer or worse, or you end up getting damage to other tissues in your heart, your brain, etc. So I hope I've spent enough time on that, and I hope that clarified it. I'm the boss. I'm going to get off of that topic and move on. Z50, Joe Riley, who should get and use an oximeter? Only those who want to get treatment earlier enough to prevent their death. Very good point. That reminds me of the title of Joseph Kraft's book about the Kraft insulin survey. Dr. Kraft was a pathologist, and he ran a large lab at a large hospital in Chicago, and he did hundreds, well, maybe thousands of OGTT, oral glucose tolerance tests, looking for prediabetes, and documenting that at each decade we get more and more and more, climbing up to way over half of us by the time we're age 60. And the vast majority of us in our 70s have glucose metabolism problems. Why am I going down that bunny trail? Because if you read the title of the book, he said, the diabetes epidemic in you. And it says, who should be aware? Who should be aware? Only those of us who want to live, or something like that. So again, very good point. David Ivers. Well, I was on David Ivers. We've got a lot of comments, and guys, this it popped up. It does that. You click on one of these, and if there's been a lot of comments, you get. Let's see if we can. It goes up, and you get lost. Okay, here we go. David Ivers. I purchased an Innovo brand pulse ox for about $40. It also has a perfusion percent reading. My pulse ox is between 94 to 95, which is what it needs to be, and pulse in the 50s and 60s. Does altitude affect ox sat? It does, but again, we're not talking about huge numbers that you would expect. That does remind me, David Ivers, thanks for bringing up the term. I think I was having some word finding problems when I was referring to this earlier, the ER doc, and when there was questions about the ER doc presentation, he was saying, look, we should be treating this more like an altitude sickness rather than a pneumonia. You get lower levels of oxygen and people get headachy and they get some problems. And he did do a good job of drawing an analogy between COVID-19, early COVID-19 disease, and altitude sickness. As you begin to talk about altitude sickness, there's a medication called Diamox that people use for prevention of altitude sickness. Now, I haven't heard any discussion about Diamox yet, and I'm surprised that I haven't. San Diego Urban Homestead Aquaponics, long name. Is pulse ox effective for detecting a HA? Headache or heart attack? Actually, usually, I mean, you often get headache when you get low oxygen sats, but as we talked about earlier, most of the time people are not aware of they're having very few symptoms. Is high oxygen a sign you're not having maybe you're talking about heart attack? For someone 4 months post-STEMI, yeah, maybe you are talking about heart attack. Is high oxygen a sign that you're not having? No. You can have really good oxygen levels. That does not mean you're not having a heart attack at all. So it's not a great way You can get injury. So I think I'm beginning to understand your question now. You had a heart attack. That's what STEMI means, ST elevation, myocardial infarction, heart attack. I think what you're asking is I had one, or the patient had one 4 months ago, and if we've got a high pulse ox level, does that mean we don't have a heart attack going on now? Not at all. Nowhere near. Pulse ox is not a way to rule out heart attack. Great question. If you're wondering about it, thank you very much for asking it. Dave Murphy, what are your thoughts on low-dose aspirin? Oh, it's interesting you bring that up. You know, there was the Aspree trial, ASPREE, and a couple of others about 12 to 18 months ago. And the interpretation that came out of the Aspree trials was low-dose aspirin is not indicated anymore. It didn't really help. Well, that was wrong in my book. I don't agree with it. And I think it's related to the fact that the doctors, for the most part today, tend to practice prevention from, you know, it's a cardiologist who's primarily a cardiologist and remembers a few things about prevention and just, you know, tries to apply that. Or a family practitioner or whatever. I know I'm being a preventive medicine snob, but here's the thing. I think we do a lot of people a lot of disservice not knowing and thinking through the details. And I appreciate you bringing this up, David. So what you saw with the Aspree trial was this. There was a lower amount of benefit and obviously the same amount of risk. You know, there's nothing that's risk-free, especially aspirin. If I were in the FDA, I'd rather them go back and make metformin non-prescription, and especially the Freestyle Libre non-prescription, but then turn around and make aspirin a prescription, because aspirin has some risks. Now, what they showed in the Aspree trial is that the benefits for people taking baby aspirin were not as high anymore. And that was because we've made progress. You know, despite the fact that heart attack and stroke are still the major causes of death and disability, even in the age of COVID, by the way. That's what the early numbers prior to the show mean. Even with that, we've made progress. We're better than we were 10 years ago and 20 years ago when the original baby aspirin studies were done. So therefore, the interpretation was, we don't think you need to take baby aspirin anymore. Well, here's the problem, and here's where we weren't thinking. The standards committees, I think, were not thinking. Maybe, I know they're thinking, but I don't agree with them. The standards committees are saying, look, you should, before they were saying if you turn age, 55, 60, you should start taking baby aspirin. Well, I understand why they said that. I mean, that's when you start getting into the risk age for heart attack and stroke. But what about the people that have no plaque? If you have no plaque, why would you be taking baby aspirin? Where else do we see that question? We make the same kind of assumption. If you have an LDL level over 120 or over 100, and some people are even saying over 70, then you need to be taking a statin. If you've got no plaque, you don't need to be taking a statin, and you don't need to be taking a baby aspirin. So if you go back and you rewrite those standards and say, look, unless you have plaque, you don't take statin or baby aspirin, then all of a sudden, the vast majority of the statin prescriptions would go away, and the vast majority of the aspirin prescriptions would go away. The people that are left are the people that have known plaque. If you've got known plaque, your risk for heart attack and stroke is much higher than somebody that doesn't. At that point, I do think you need to be taking baby aspirin. So again, maybe you asked me what time is it, and I told you how to make a watch, but the bottom line is this. For people that have plaque, I think you need to be on a blood thinner, either low-dose aspirin, baby aspirin, 81 milligrams daily, or You also, by the way, are in that risk category at that point. If you have plaque, you're also in the risk category to have the other chronic diseases like high blood pressure and, by the way, unrecognized paroxysmal atrial fibrillation. So I think you need to rule that out. If you have atrial fibrillation, aspirin doesn't work as well. You need at that point to be on one of the NOACs, novel oral anticoagulants like Eliquis or Xarelto. David Murphy, is asymptomatic WPW anything to be concerned about with COVID-19? WPW, Wolff Parkinson White, is a very, very different type of issue. It's more of a genetic variation in your conduction system within the heart. Totally different mechanism. I haven't seen anything that indicates it's a significant added risk factor for COVID-19. Joe Riley, the Apple Watch will warn you if you go into atrial fib. Yep, I'm glad to see the stuff they have about the Apple Watch. You know, you had some cardiologists. There's a cardiologist in England who does a lot of YouTubes, and he discouraged folks from getting the Apple Watch to look for atrial fib. Here's why. He said, you've got all these 20-year-olds that are getting Apple Watches and getting worried about whether or not they have atrial fib. I think that's a valid point. I don't think that a healthy 20-year-old needs to be worried about whether or not they've got atrial fib and shouldn't be even getting the watch for that reason. The problem that I have is that, you know, again, it's the same thing that I said before. The vast majority of adults that have, and especially baby boomers, that have prediabetes don't know that they have it. Just like the vast majority of baby boomers that have atrial fib don't have it. So I clearly recommend a baby boomer to get an Apple Watch. Well, not an Apple Watch, and I'm not paid by Apple. I don't get any affiliations from them. There are plenty of other options as well. You just look on Amazon for atrial fibrillation monitor, and you'll see dozens of them. Apple Watch is several $100. You get others that are like 100. Now, there is an advantage to the Apple Watch, and I covered that in my video on it. The other ones, if you just apply them, you have to be having some sort of symptoms, and the most common symptom is like, I remember when I woke up with it a couple of years ago, it was like a trout flipping in my chest. A lot of people have zero symptoms at all. And so if you've got a screening mechanism and you have to have symptoms before you apply it, then you're still going to miss a huge portion of people that have atrial fib. So that's where the Apple Watch really starts to come in and play a significant role as a potential improvement in detection of atrial fib in our population. So thanks for bringing it up, Joe. Bob Bell, if you think about going on Eliquis or Xarelto, consider the extremely high price, direct and copay, and in donut hole for Medicare. These are extremely expensive medications, Bob. And here's one of the things that I've done. The pharma themselves actually have some good programs for folks that are uninsured, in between insurance. Their insurance doesn't cover it. I actually was in one of my retirement phases when I went on Eliquis and actually started off on one of their programs where they made it less expensive if you were in between insurance. Since then, I went back to one of my previous jobs and was covered for a while. But yes, consider that, but also don't think of, well, I can't get it, until you've investigated a little bit more deeply. Another good way to do that is GoodRx, GoodRx. And I don't know if they've got an Eliquis program with GoodRx yet or not, because I'm still on Cobra from my, I just went off Cobra from my previous job, my last day job. Jackie Shaheen, Doc, have you worked with nattokinase as a natural blood thinner? I have, Jackie, and I've got a video on it. You may not like it. My bottom line on it was, great idea. I believe it's a protease. It's a protein, a stuff that decreases, that helps dissolve protein. And the assumption is it'll help dissolve things like potential clots, scar tissue, stuff like that. And a lot of people swear by it. When I reviewed the literature, the science, I did not see, it wasn't nearly as dramatic as a lot of the, the individual discussions where people said I had a great reaction to it. And here's the thing, last thing I'll say. I suspect there's a problem with getting nattokinase through the gastrointestinal system, the stomach acid denaturing the protein in it. Now, it may be an issue where I just haven't discovered the right stuff. I used to be a critic of the hard evidence behind vitamin K2. After studying it a little bit more deeply, I realized I went away from just the randomized clinical trials and started looking more deeply at things like some of the enzymes and some of the relationship with prediabetes. And at this point, I am a believer in vitamin K2. Not yet a believer in nattokinase. Again, just not seeing a lot. I know I've seen individual experience statements, but I've just not seen a lot of good evidence, especially clinical trials, which would indicate that it's what a lot of people think it is. M. Frusciante, COVID-19 search, as your website's net.net. Search tool consisting of 70,000 COVID-related research papers. Yep. As we mentioned last week, we covered an article on, there's what we would call a cacophony. In other words, a chaotic set of noise around developing research around this thing, this entity. Unfortunately, it could be coordinated a lot better. And maybe you're talking about the point that John Panazzo and I brought up where, some things seem to be really obvious, but you just have a hard time finding them. Again, that's a part of the reason for this, for these YouTube lives. Speaking of which, we've gone over quite a bit, and we've got a lot. I'm going to cover a few more. And again, if you're not interested, you can drop off. No trash in heaven. Dr. B, you're not afraid of your vitamin C causing oxalates producing kidney stones. I've actually had kidney stones. And yes, there is some concern about vitamin C causing oxalates and kidney stones. I had actually gone off of vitamin C. That being one of the reasons. Another reason because I was a little bit of a skeptic. And then I started restudying vitamin C based on some of the attention it was getting with the COVID-19 virus. And some of the stuff I was reading said, you know what, I think I will go back to, so I restarted it, a couple of months ago for COVID-19. And don't get me started on my kidney stone story. I had a stent in my ureter for over a month. For those of you who don't know, a kidney stone is major pain. I remember I was told for 4 weeks that I didn't have it. Well, finally we were able to diagnose it. And sure enough, we went first we tried to pass it, couldn't pass it. Went in to get it removed. They couldn't remove it. The ureter was too tight. The ureter is the tube that goes from the bladder up to the kidney itself. And so then they put a stent in there. And they said, leave that in, it'll probably come out. No, it didn't. Ended up having to go back in, another procedure. And I was asking my mom about this later on. I was telling her this problem. She said, I said, did we have any family problems with kidney stones? She said, Oh, you know, you never asked. You had an uncle that died in his 40s from this. And I'm going, after I've been telling all these docs that I don't have a family history, maybe I should have asked. Light in the Dark, $4.99. Thank you very much for your contribution. What do you think about COVID tests from what might be considered to be trusted sources that are reported to be contaminated with the virus? I obviously have been very involved in the COVID test area. I have been inundated, just buried in stories about, oh, well, we can get you 6,000 test kits. We can get you 250,000 test kits, and the test kits never appearing. So in other words, the shortage. I've also been eyeball deep in, this return to work issues and the antibody tests and the problems associated with poor antibody tests and even good antibody tests really not giving you the assurance you need. And we can go into the details. Those of you who didn't see that video, the bottom line is, even with a respectable sensitivity and specificity, the prevalence of COVID-19 infection at, let's say, 2%, let's say it's even 5%, in those low areas, even with a good sensitivity and specificity, if you get a positive antibody test, it's as likely to be a false positive as it is to be a true positive. Now, that sounds like physician, lab test, epidemiologist, mumbo jumbo until you think about what that means. You're thinking about going back to work, you get an antibody test, you think you're, okay, I'm safe, but the probability of that being a false positive antibody test is just as high as the probability is that you actually have had the infection and don't have it. So you start to think about that, and you think, that does matter, even if I did think it was clinical mumbo jumbo. That also helps you start thinking about all these surveys that came from places like Santa Clara, where they're saying, oh, this virus is very common out there, we just didn't know it. No, they had zip code areas and things like that where there were 2 tests done. One was positive, one was negative, and they're assuming that they have a 50% positivity rate. It could have been 0 as easily as 50%. So a lot of stuff about SARS-CoV tests. I haven't heard anything yet. Pardon me for going down those bunny holes, but I haven't heard anything yet about coronavirus tests that were contaminated with the virus. It's just not making a whole lot of sense to me. Are you saying the needle where you're getting a blood test is contaminated with it? Because that doesn't make any sense. Or are you saying that the swab that they're putting down the nose to get a swab sample is contaminated? Because that doesn't make any sense. Or maybe you're saying the test kits themselves are going to be false positive because the test kit is contaminated. Again, not very clear, but thank you. Thank you for your, if you can clarify for me for the different ways I'm interpreting your question, I would appreciate it, and maybe take another shot at it. Andrea Harwick, are the handheld UVC appliances effective for killing the cocoa? I think that looks like autocorrect for coronavirus. UVC appliances. Well, it depends. Yeah, I mean, yeah. From what I know, and the environmental cleaning section is not my space as much as some of the medical side, but from what I know, yeah, the UVC does do it. Somebody fact check me and correct me if I'm wrong. But again, some of the challenge on the UVC is where you can apply that and where that's going to make a difference. It's going to make obviously a much bigger difference in environmental applications rather than obviously physical. Light in the dark. They really do a number on candy bars too. Not sure. Oh, are you talking about contamination of candy bars? Andrea Harwick, are they well, I'm getting some repeats here. Jan H, Dr. Brewer, different guy, very timely perspective with another ER doc putting 20 hours per day. Got to hear him. There's research out on UV. Eliquis and Xarelto are not for patients with heart problems. Tricky Vicky, sorry I was late. Why do I need to check my SpO2? Tricky, what I think I'm going to suggest that you go back and review the video because, gosh, we've been going on for almost an hour and a half here. And bottom line is this virus, coronavirus, tends to drop your blood oxygen. You don't tend to notice that, and you can get into real trouble real fast. So that's why people are suggesting you consider getting a pulse oximeter. Also, I'd like to see a statistic on how many CV plus took flu vaccine. Are you saying CV plus, does that mean coronavirus? I think that would be an interesting statistic because you saw some of that in the JAMA article where they were saying, what was it, 2 or 3% had a comorbidity or a co-infection with another significant virus like flu. So very interesting point, and that may have been where you were going. And they were obviously asking that question, and many of us have asked that question, and that is, how much of this is really seasonal flu versus something else? And I think that helps lend a lot of credibility or a lot of information to that question. And I think the answer is what most of us have suspected already, and that is, this is not the seasonal flu. And seasonal flu is not causing this. And some sort of, for those of us who are thinking, well, the people with COVID-19 are actually getting both flu and COVID-19, that's probably not the case either. Light in the dark. Let me see how much, gosh, we're getting way on into hour and a half, and we got a lot of questions. I really appreciate the interest. We'll see if we, maybe if you could apply or come back tomorrow, we can cover some more of these questions. I'm going to have to go. Thank you so much for your interest.